Thank you so much for the kind introduction. I'm going to share my screen. Thank you. So I'm going to try really hard. As Dr. Tekacheva said, my background is in academia. And so it may be a little bit weird that I'm sitting here talking to you today about this. So just a little more color for how I got here. I am still affiliated with Duke University, but I like to say I'm in my 4th year of a 2-year stint with North Carolina's Department of Health and Human Services. And so I was doing research in mental health and informatics, informatics to enable precision medicine in mental health in particular, learning healthcare system, all those things. And then through serendipity, a friend of mine from grad school had been consulting with the state of North Carolina and said, hey, you should talk to them. They're starting this data office and they're hiring a chief data officer and you should talk to them. So I did, and here I am almost 4 years later. And it has been eye-opening and interesting. It was eye-opening and interesting even before COVID hit. So I'm going to tell you a little bit today about what that experience has been like. If you have any questions that are sort of specific about a slide, feel free to ask as I go along. I'm not sure if I will see it, but if Erica could let me know if there's something that comes up. And otherwise, we can do questions at the end. Okay, so I did not know much before I got here about what the Department of Health and Human Services was or does. And so it turns out so different states have it shaped differently, but North Carolina, HHS takes care of many different things, public health, obviously, but also Medicaid is the huge aspect of it, especially from a financial perspective. Mental health, a lot of state operated health facilities, mental hospitals, child services, child support, child welfare, low-income services, things like food stamps and women and infants nutrition programs, vital records, so births and deaths, lots of other stuff. So that's sort of the scope of things. And as I mentioned, the leadership of DHHS back in 2019, it was Secretary Mandy Cohen. She had been part of the Obama administration, then came down here in 2017, I think. So they decided, hey, we really need to make data whole, recognize consciously the importance of data. If I'm able to, I'm just going to move this thing so as not to distract me to a different thing. Okay. We really want to recognize the importance of data and give it front and center role in the organization. So they established the data office. It's led by a chief data officer, which is me. And it's meant to drive department-wide cultural transformation. So whereas previously, for decades, the department has existed and provided services to the people of North Carolina, they said, okay, we're not going to just have data as sort of a byproduct of that sitting to the side and gathering dust on a shelf. We really want it to be a first-class citizen and recognize that a strategic business asset. And so I came in and worked with my then deputy CDO to develop a strategy and roadmap based on 5 pillars. You can see them here. I'll go into a little more detail. Data infrastructure, that's just sort of the IT underlying stuff of how do we store the data and access the data. We are not part of the IT division. We are our own organization separate from them, but we partner very closely with them, of course. Data governance, so that's things like how do you request access to data, who decides who gets access to data, what criteria do they use to decide who gets access to data, all of that sort of process flow governance aspect. Data quality, actually, I'm going to go on to the next step for a little more reference. Data quality, which is often considered part of data governance, but it had been sort of neglected and just assumed or pushed aside for so long. We wanted to really call it out and give it some emphasis. Data literacy, so this is workforce training across all the levels of the organization. When I first started, I went to a conference where they used a very useful expression, which was raising the ceiling and raising the floor. So there's some people around here who are whizzes with Excel and can do amazing things with pivot tables. And for them, we want to give sort of best practices in coding and versioning and understanding what a data standard is and why you might want them. And then there's people who kind of break out in hives at the mention of data and are very uncomfortable with the concepts. And so just giving them sort of a familiarity, data literacy, understanding the concepts. And then finally, data use. I think when they created the data office, some people thought like that was what we were going to focus on, of like, oh, we're going to do all these advanced analyses and predictive modeling and reports, and it's going to be great. But public health and health and human services is historically underfunded. And so it's really focused on survival and doing the minimal they can do to get by. Which means that from a technology perspective, you have a lot of access databases, a lot of faxing and hand entering data. So there's a lot we had to do before we were able to get to the level of data analysis. So this is a slide we affectionately refer to as the staircase slide that my data office director put together. So go to walk before you can run. At the bottom left is all the sort of base foundations, the informatics and data foundations, just efficient data collection, not faxing, emailing, ideally, actually not ideally emailing, but sharing files that are tab delimited or comma delimited rather than Excel if you're lucky and a PDF if you're not. Data cleaning, data pipelines, integration of data between our different silos. Then you can get up to kind of reports and dashboards, drilling down into interactive dashboards, then doing some more advanced queries and analyses. So I would say the vast majority of our time has been spent on the bottom 2/3, 3/4 of this staircase. We're finally getting to the point where we have the luxury of actually doing some of these interesting analyses. I like to emphasize, especially for academic audiences, that academics tend to focus on this of like the latest deep learning model and how many layers and the ROC and what is the improvements we get in accuracy. What most of the world really needs is just a simple SQL statement with like a summarize and group by. In the context of public health, often there's a geospatial aspect, which gets to be useful to be able to map things, not just at the state level, but obviously more granular than that. But that's really what we need to understand. One other thing as sort of foundation for the talk is people are probably familiar in this audience with the concept of a learning health system, where historically, ignore the purple here. Historically, you have evidence, you sort of do research, this is the gray around here. That research leads into evidence for clinical guidelines, and then you put that into practice. Learning health systems, this concept has been around for more than a decade, I think at this point, is where you close this loop. So you have health practice, and each time a patient sees a doctor, you're collecting data. Let's not just put that aside and keep it in the record. Let's actually use that data to form more evidence to make this a cycle. So instead of just evidence-based medicine, we have evidence-generating medicine, and that helps to inform the way we practice moving forward. Similarly, one of the sort of earliest aha moments I had with Secretary Cohen was we can do this at the policy level in DHHS. You have policy impacts outcomes and the way things are done and the way people live and the quality of life and their health. You have outcomes, and then you can use that data, again, strategic business asset for the department, to inform policy, to evaluate the policies we've done, and then to potentially change policy. So one of the really early examples I saw of this that was sort of discussed a lot was this example turned into a New England Journal paper by Secretary Cohen and the guy who was a CDO before the data office was really created, Aaron McKeithen, where they were trying to look at, in the context of Medicaid, you have a lot of women in Medicaid who get pregnant, have babies. And the qualification, the eligibility criteria for Medicaid is very similar to the eligibility criteria for something called WIC, Women, Infant, and Children, and that's this nutritional program. And so if you have women who are eligible for that, you're going to get much better outcomes on average for them and their babies if you've got this additional nutritional supplement. So they wanted to ask the question, of the women we have in Medicaid who have had a baby, how many of them were also enrolled in WIC and getting those benefits? And just asking that question took months to answer. And it was because all of these data lived in siloed places. In this case, they actually even had a common identifier. That can be a challenge sometimes. But they lived in different places. They were under different legal agreements and requirements for what was allowed. And it was just a mess. And so it took a very long time to get this diagram that in a good data system, you should be able to get in like a few minutes, maybe a few hours with specifications. So in order to do this kind of thing, you need two things, as I mentioned. One is to connect these different data silos that we have. And as mentioned, you've got public health and you've got mental health and you've got Medicaid, and all of these live in different places. And then social services and food stamps, As part of that, they all live in different places. Some of them use the same identifiers, but many don't. And so for the ones that don't use the same identifiers, you need that ability to figure out Waldo is over here and then looks very similar, but maybe a tiny bit different. Maybe there was a typo or something over here. Figure out that that's the same person in those two different data sets. So this is where we were trying to work toward integrating our silos and getting our foundations in place. And then, as we all know, COVID hit. So in North Carolina, it was March 10th, 2020, that we had a declaration of the state of emergency. When this happens, when there's a state of emergency declared, this building here on the bottom left is the State Emergency Operations Center. It becomes sort of headquarters. It actually has this room that's called the Situation Room. This is a picture from inside the Situation Room. This was pretty early on. It was before we were masking, when there weren't enough masks and they were all being used for healthcare providers. People are mostly 6 feet away from each other here. You can't see that there was like hand sanitizer every 5 feet or so. And so there were a lot of questions we had when that was happening. How many cases are we going to see? When will our epi curve peak? How much extra PPE is needed and where can we get it from? You may remember there was just there were a lot of players in the space saying like, we've got N95 masks. And it was hard to make sure that it was legitimate. Will we run out of hospital beds given that epi curve? What about ICU beds or ventilators? Should we shut down bars and restaurants, schools, businesses? It's funny kind of giving this, 2.5 years later, where in hindsight, obviously we did. But at the time that felt like a really big deal and a really big, scary question to have to answer. And can we support families who are unable to work either because their workplace is shut down or childcare is unavailable? So we needed to get this massive effort to understand where is the childcare available around the state and how do we connect people with that childcare as needed. So we had a lot of different, what we refer to as buckets of these different data types. And I know this is a sort of ugly, colorful slide, but it's really meant to say these buckets were very different in shape, size, nature, quality, etc. So the different types we had, obviously testing and cases for positive testing. Med surge is medical surge. So that is like how many hospital beds are taken, how many ventilators do we have, how many people were admitted with COVID, where there's a distinction to be made of admitted with COVID versus admitted for COVID. We had wastewater, this was later, but measuring in the wastewater. Also later was vaccine data. I remember the day they said, okay, this was 5 months into the pandemic. And they said, okay, we're going to stand up a new work stream for vaccines. And it was like this light at the end of the tunnel. And here we still are. PPE I mentioned, so that's the gloves and the gowns and the face masks and all of that. Contact tracing, and then monoclonal antibody, different treatments we had. So I don't want you to necessarily understand this. There's no way you could understand this slide. What this is meant to say is at the beginning, these were our different buckets, our cases data, our test data, our med surge or capacity, representing stuff, staff, and space was how it was explained to me at one point. These arrows all represent manual processes, usually emailing an spreadsheet and or a PDF. And so you had the epidemiology team who got data from cases and they would email something to the comms team. You had the state public lab doing the tests and they would email something to the epi team, but also something to the emergency management team, et cetera, et cetera. Initially, in terms of tests, the guy at the Emergency Operations Center, who is usually the person who would like hand out sandbags in hurricanes, that's usually when the Emergency Operations Center gets activated. So the guy who usually did the sandbags, he was literally calling up LabCorp on the phone and saying, how many tests did you do in North Carolina yesterday? And how many of them were positive? This was clearly not scalable, not something we were going to be able to do over time, keep up over time. So we had to build a lot of different of those pipelines I mentioned for automation. This is still a pretty complicated slide, but let me break it down to show you how clean and elegant it is, relatively speaking. Now we have our different buckets along the bottom. Each of these sources goes through an ETL step, extract, transform, load, or I guess in this case, transform, load into what we call BIDP, our business intelligence data platform. So it's sort of a reporting server. Now all of that lives here together. then it goes through a process to automatically refresh our publicly facing dashboards. So these are the dashboards that had to be done every day, that the media checked, that the governor checked, that a lot of businesses and local schools and would look at to say, like, how are we doing, trending? What do we need to do different? So not a lot of room for error. A lot of work, a lot of people having to wake up. So this is nice and automated, many aspects of it, but it still required a lot of work to start at like 5 a.m., 6 a.m. to get this done so it could be posted late morning every day. Another thing I want to emphasize is that seems relatively straightforward, but the devil's in the details. I mentioned the med surge aspect of how many beds do we have that are free versus occupied. So it seems pretty straightforward. You've got beds. You've got staffed beds. So you need to have, a nurse or someone working there. Some of those are ICU beds. Of those, some of them are occupied, some of them are not. So far, so good. But you have staffed beds, you also have physically available beds. And so you may not always be staffing all of the beds. There may be some beds available that you don't need. And so you're not going to have nurses or doctors around to staff those because you don't need it and it would be extra money. Beyond that, you may have additional beds that the hospital is licensed for, but that haven't been built out. And then beyond that, you've got the outpatient and observation beds. So these are the kinds that, when you get to the ED, you kind of lie down on it, but you're not expected to stay overnight there. And then there's this concept of surge beds of like, oh my God, the roof is falling. We have so many people, we need more beds. And different hospitals kind of define that differently. So some of them, it was the additional physically available beds, like, oh, now we're going to staff that up. Some of them were the licensed inpatient beds that had never been built out before, and now they were building them out and staffing them. Some of it was like, okay, we're all hands on deck. We just need a place to put this person. You can use those outpatient and observation beds. And then sometimes it was beyond that even. It was, well, we've got a tennis court next door, and if we really needed to, we could put a bunch of gurneys and we could do something there. So just agreeing on definitions like that was a challenge. Here's the part where we talk about sort of biostatistics and modeling and the interesting analysis. I'm sure you remember this curve of we need to flatten the curve. We need to make it so that not everyone is getting sick and we're getting this peak curve and we're exceeding our capacity. If we flatten the curve, the people will still get sick, but it'll be further off and we'll have enough resources to help treat them. So we compare this to hurricanes. We have models. And we DHHS partnered with different universities near us, UNC and Duke, and RTI International, which is a research institute in the area, looking at different models and saying, okay, based on what we're seeing, when is this going to peak? How high is this going to peak? The challenge here is it really relies on that key. It was R0 at first, and then R naught. Now I've forgotten the notation, but basically that. How contagious is this at this time? And that depended on different things, different strains, different levels of exposure, of people going around, how much they were interacting with each other. So when you see a hurricane map like this, it's not that they had just one model. They took a whole bunch of different models, averaged them, and then kind of this is the main path that you see. This is sort of a more detailed version of what you're seeing when you see those hurricane maps, and they just average them and make it look neat. And so that's what we were doing with the models. This was one of my proudest moments where I was made into a cartoon hero for Duke Alumni Magazine explaining this analogy with the hurricanes. And importantly, people, if things went a little bit differently than was expected, we thought we'd have this many cases and instead we had this many cases. It's not that the model was wrong, it's that we ended up in one of these sort of outer bands of the average of it was somewhere else in the curve of what we were expecting. So the model that we used the most was a geospatially explicit agent-based model. And this was from a group at RTI, Dr. Sarah Ray and others. This agent-based model included about 10.4 million agents. So that's the population of North Carolina. It was based on a synthetic population, so a sort of pretend population that roughly matched the demographics of North Carolina. And then each agent had these different attributes, and they were modeled of going over the course of their day and getting sick or not. This was also using what's called a SEER model, or susceptible, exposed, infectious, and recovered. So we knew that the population at the time, and actually still looks more like this, where you have, one person died here up at the top. You have various other people who get sick but do not die. You have a lot of other people who are sick, but we don't know that. They may be symptomatic, or they may be asymptomatic, and we really don't know that they got sick. Over time, as you know, we had a lot of different availability for testing. So at first there was very limited testing overall. Later there was more testing available at your doctor or at Walgreens. And then later on, now it's a lot of it at home, which makes the cases dashboards a lot less reliable because there's so many cases at home that we're never getting reported. Pardon me. So the model here is you go from susceptible to exposed with some transition probability to infectious with some transition probability to recovered or death. We later learned that once you're recovered, you can still get sick again. So you can imagine this being cyclical. So what this gave us was graphs over time that showed what we were expecting the demand to be. So this blue curve with some error bars. And then the red line was the maximum capacity in the state. And they would do it with different REs, different sort of reflections of what we expect the transmissibility to be. I apologize if there's any epidemiologists in the audience. I'm probably a little bit fast and loose with some of these terms, but the concepts remain the same. So we would model it with different REs. Here you can see that we are approaching about 30 days out, possibly exceeding our capacity. So as mentioned, this is some of the most advanced modeling being done. When this happened and when we saw this reaching capacity, it didn't cause us to panic. What we did was we sort of checked in with the people on the ground and said, does this feel right to you? Are you worried that we're going to get to here? And they, based on years of experience with flu and other things, sort of gauged it and said like, no, we're okay. I'm not worried about that. So I wanted to point that out that even with this advanced modeling, when the model was saying, you should start to worry, it was really the people on the ground that we relied on rather than the advanced modeling, because there's some flaws here. And so over time, we would see how well it tracked, and sometimes it tracked well and sometimes it didn't. One thing that is worth noting that I never expected in academia, where we do use AI a decent amount, is something called RPA, or robotic process automation. Over time, okay. This is software to basically perform mindless human tasks. Often it's to make up for poorly designed and or non-interoperable systems. So there's various things where we're supposed to be reporting to the feds, and it involves, say, taking an Excel spreadsheet and pushing it to an SFTP server. And that's something that a person can do each day, but you can also train a robotic process piece of software to do that. And so that's actually where it's helped. We had one epidemiologist who had been having to get up and do some manual task every morning. And it was a very exciting day when she was able to just take her dog out for a walk instead of having to wake up early and do that. This is a little bit of a good breaking point. Any questions so far? Can I see if there's any questions?
No, there were no questions in the Q&A yet.
Okay, great. So we all know, you've probably heard in various contexts, that COVID disproportionately impacted historically marginalized populations. So these are heat maps of cases and deaths across the country, and you can see that different areas, this is of African Americans' share of the population. So in different states where it's especially orange, we see that there's a much higher proportion of cases or deaths or both in the African American population. You can't improve what you can't measure. And so we, from the start, were really focused on making sure that we were able to measure and understand what the demographics were of the population, both being tested and testing positive and dying, and a particular push with vaccination, because that's something that we could really do something about. So we wanted to understand what is the distribution of race and ethnicity among our cases, among our deaths, among the people being tested. And that was really challenging because historically that information hadn't really been collected, so it wasn't part of the workflow. And then similarly for people being vaccinated against COVID-19. And North Carolina was nationally recognized for this. One thing that helped is that we did not use our standard vaccination software. We needed some functionality that it couldn't provide. And so we sort of built from the ground up for COVID vaccinations, which has pluses and minuses. It was a huge lift and it was a lot of work. But it meant that we didn't have to worry about sort of bad practices in the past. We were training everyone anew. And so we were able to train them to do things the right way and customize it to do something like not allow them to go on to the next screen unless they have entered race and ethnicity data. So this allowed us to do a lot of, again, data-driven policy where we could see that we were having a lot more, for example, white members of the population who were white getting vaccines than members of the population who were Black or Native American or Asian. And so that enabled us to say, okay, we need to target these areas. We need to get into neighborhoods, partner with community-based organizations to get people to vaccine events. And we were able to trace over time and see that we had it's probably hard to see here, but the blue here is the Black or African-American population. And so we saw it started out very small, got bigger over time, and we were able to see some of the impacts of the partnerships and the events that we planned. This also allowed us, collecting this data, to do things like this graphic here is a scatter plot. Along the x-axis, you have the population of the population of the historically marginalized population selected. So here we've selected Black or African American. So the x-axis represents, say here, approximately 55,000 Black people and the dots I should have said are zip codes. So in this zip code, you have approximately 55,000 Black people who live there. The y-axis represents what percent of the population is vaccinated in that zip code. And the solid line up here is the state average. The dotted line here is the average for that population. So the places we really want to focus on having community events are going to be the ones under the average line with relatively large numbers of people so that we can bring the vaccine to people where they are, make it as easy as possible for them to just walk down the street, be passing a store, get their vaccine. We also were able to do this map. This is just at the census tract level. So these are really neighborhoods. The red blue is social vulnerability index. So how well off that area is. And you can look up, the CDC defines social vulnerability as a combination of a number of different elements. And then the teal circles are the relative number of people in that area who are vaccinated. And so the blue tends to be relatively well off. Big circles have a lot of people vaccinated. The red areas are where people are more social vulnerable index is higher. They're more vulnerable, and the smaller teal circles represent a much smaller number of people having been vaccinated. This area, I think, is around NC State a lot. And so people may not be registered as having that as their address. They may be students from other places. So that may be why those were so small. But again, these kinds of analyses and visualizations allowed us to take action and plan our events to be in places where vaccinations were most needed. So that focus on equity has been a focus not just in COVID, but really across the board in DHHS while I've been here, which is some of what's made it so rewarding. We know that a lot of someone's health outcomes have to do not just with their health care, but all of these other aspects: childhood experience, housing, education, et cetera, also referred to as social determinants of health or non-clinical drivers of health. When I first started at DHHS, we were working on Medicaid transformation. So transformation from fee-for-service to managed care. We have since gone through that transformation, and there's something called an 1115 waiver from CMS. And what that is a waiver that basically says you can spend Medicaid dollars in creative and innovative ways that aren't normally done and see whether that helps improve outcomes. So North Carolina took an approach to implement a groundbreaking program to pilot evidence-based interventions addressing issues like housing instability, transportation insecurity, all of these social determinants of health to try to improve outcomes. And this meant that we were able to use Medicaid dollars not to just reimburse for going to the doctor, getting an x-ray, getting a cast, getting a drug prescription, but also for getting a ride to the doctor, getting a ride to pick up a prescription, help with first and last month's rent for someone who wasn't able to pay for that themselves. The goal being that over time, we can both improve outcomes and save money. There's still formal evaluations being done in North Carolina. Other states are working on it as well. And so we're trying to say, like, what does the data tell us for how to handle this? It's not just North Carolina, as I mentioned, other places are doing this too, where hospitals are paying for some level of housing. And if it keeps someone out of the ED, it ultimately saves them money. Also Lyft, getting transportation to pharmacies or doctor's appointments. So in North Carolina, for every Medicaid beneficiary, there's a series of these screening questions that ask different, so I don't know if you're able to read this, but in these different categories, food, housing, transportation, interpersonal safety, kind of, is there a problem here? And then depending on the screening, there's a system, a platform referred to as NC Care 360. This is a closed loop referral platform. So you could think of it as having three main types of data. One is these community-based organizations, so like the Interfaith Food Pantry, and I guess these are all Interfaith Food Pantry, but different homeless shelters, soup kitchens, referral services, interpersonal violence counseling, different services that can help a person. So we have a directory of that in partnership with 211. We also have records for the various people in Medicaid and not in Medicaid who are seeking services. And then there is the referrals. So for this person, Jane Smith, I can say she is in need of, say, healthy vegetables. Well, here are some food pantries that have produce boxes. I'm going to refer her to these. And importantly, this is a closed loop system. So these food pantries are also on the system. They can go in and see, yep, I see the referral for Jane Smith. I'm taking this one, and then resolve it. Say, I have given her this food box. And so we have this closed loop system to understand which of these needs have been addressed. Again, both for Medicaid and beyond. So this has been a really interesting system. There's a great article about it recently in which they, a very big understatement of, it was a big lift. It's been a huge lift, and it's still ongoing, and it's still, you know, relatively version 1. We've got a lot of work still to do, but really exciting direction there. So the goal here, both in the context of COVID and more generally, is to really look at whole person health, not just give someone their food benefits, not just give someone their Medicaid benefits, but look at residents on the whole and understand all the different touch points and all their different experiences. As mentioned, this requires the ability to integrate the data across our different silos and to link between those. Some of the questions that this enables us to answer then are things like, which % of Medicaid beneficiaries have been vaccinated? So if we know the answer to that, we can offer carrots or sticks for the different insurance companies participating in Medicaid to say, company A has 60% of its beneficiaries vaccinated. Company B only has 30%. Company B, you're going to have to do some things to get that rate up, or else you're going to get a lower reimbursement rate. Which children in foster care have prescriptions for more than 4 psychotropic medications? This one always kind of breaks my heart. But we have social services and child welfare programs tracking kids in foster care. We also, they're paid for by Medicaid. So those are 2 different data silos, and combining them is going to help us understand what's going on with the kid. And that would be flagged to say, like, someone should really look into this. Who receives regular food assistance referrals? So I mentioned the NC Care 360 platform, and therefore may benefit from SNAP. SNAP is our version of food stamps, but is not yet enrolled in it. And those may be targets for targeted outcome to say, hey, did you know you're eligible for this? What % of people experiencing homelessness have been vaccinated? So we've partnered with external organizations. We don't actually own homelessness data in the state, but we've partnered with organizations that have it, with very obviously strict rules on what the data, who the data can be shared with and what it can be used for, to try to improve the vaccination rate among the homeless population. Oops. And then finally, what's the relationship between early grade outcomes, things like 3rd grade reading, and different early childhood conditions, things like early learning and health and housing, and some of these other things that we know contribute to outcomes. This one is interesting because it's a partnership with another state organization, the Department of Public Instruction. So it's not enough to just integrate our silos within DHHS. We're also looking to partner with others around the state. Public instruction is one. We also look to partner with commerce and justice and other areas. Thus enabling whole health, where the person is really at the center of everything, and these different circles represent these different services or touch points they may have with the state. So I'm a few minutes early. That is the gist of what I wanted to get through, and I'm happy to take any questions. And I will stop sharing my screen.
Thank you so much. That was very interesting. So we have one question from the audience. And the question, I think you partially answered it, but like, was collecting racial data on vaccination used to address vaccine hesitancy among certain racial, ethnic, and economic groups?
Yeah, so I wouldn't say that. So yes, it was helpful because we first just needed to know what the differences were. Just knowing it, though, doesn't address the hesitancy. The bigger thing there is once you have the data, you have to do something about it. And we had a lot of partnerships with what we call trusted messengers. So the former secretary, Mandy Cohen, she's a white lady from New York and, an educated MD kind of thing, and wasn't necessarily the best messenger for certain populations who very understandably have some hesitation with the system and the government. So we partnered with local organizations, different race, different ethnicity, different languages, to try to get people there who supported this and understood the issues to represent their group, to represent to the groups who they were engaged with already, to try to get them to get over the hesitancy aspects.
Thank you. So I also had a question going back to your earlier explanation of the design of the data and the, that one of the questions is data governance and who has the access to the data. And the other issue that one of the expectations that the department will be doing a lot of the analysis, however, because of the underfunding and other issues, is there is some to be made. So I wondered if there is some programs that are available for researchers to sort of for collaboration and having some established ways to access the data for maybe academic epidemiologists to take a look.
Absolutely, yeah. So that's been, I was going to say that's been a focus. That's been a back burner. We can't wait to be able to do this thing. We also have, there's something in North Carolina called the Office of Strategic Partnerships, and they're meant to be kind of matchmakers between state agencies and researchers, so that researchers are working on the questions that state agencies will actually find useful and actionable. So we have some of that going on. We also have some external to the state people working on some of like our early childhood data to do some analyses. So the short answer is yes. And the longer answer is it depends on the question, it depends on the data, and certain agreements need to be in place. We've been working really hard to make it easier to exchange data within DHHS, because unfortunately those different branches I mentioned are considered in some cases different legal entities. And so it's endlessly frustrating to say, I'm in Medicaid and I need social services data. Oh, well, you need to sign a legal agreement between people who both work for DHHS. We've gotten that a lot better. But for external parties, there's always going to be that sort of legal agreement data use thing that takes longer than we want to happen, but is still worth it in many cases.
Yeah. And I also was wondering about the data privacy and access to sort of protected information. So are there some routine procedures for, data, make them more anonymous, or providing certain synthetic data sets that takes care of, with summaries or so? As far as I understand, there's sometimes practices of producing synthetic data based on the real data, which is not vulnerable to the breaches of confidentiality. How is that organized?
There's a lot of people and a lot of good friends of mine who are very smart and I respect, who are really psyched about synthetic data. I'm not one of them. From my perspective, ultimately, you're going to need the real data. And so I think synthetic data is useful for two things. A, it buys you time because these agreements can take months to get into place. And B, it can be good for training purposes. If you have students just, getting used to doing sort of data cleaning and wrangling and manipulation and just making sure that things are the right format, that can be useful. But ultimately, someday you're going to need to get that real data, because otherwise you really can't tell if the distribution or the pattern you're finding is going to be in the data itself. That said, we do have some ways that so for our public facing dashboards, if you have, an older person who is Native American in certain zip codes here, that's pretty identifying. And so we do small cell suppression for our dashboards, where it just says if it's like 5 or under or 10 or under. I've forgotten the details. I know at one point in my life, my director and I, we were like, oh my God, small cell suppression is going to be the death of me. It's like, it seems simple. And then there's all these like sort of edge cases where you're like, oh, so interesting stuff. Another question, as a genomics enthusiast, was we also in charge of genomic surveillance. I was not in charge of genomic surveillance. I did not contribute to Next Strain. I sit on all the calls with the people who report on those. But no, it was, especially given my genomic history, I have not really been part of that at all. Sorry. But we have endless exciting or endless fun jokes about the wastewater surveillance. Yeah, it kept things light at a dark time.
Well, I personally found it interesting, this wastewater monitoring. It seems to be a bit give you information a bit ahead of the cases from the testing, so you know what to expect.
Exactly, and we've gone from daily dashboards to now we just do weekly dashboards, and we have certain values on those dashboards, and they're things like hospitalization, cases, vaccination, and wastewater surveillance. That's the first one I look at, because that's the one, it's the leading indicator. I don't trust cases at all these days, because barely anyone is actually getting it done at a place. They're just buying your whatever thing from the drugstore and doing it, never reporting it. So yeah, it's been fascinating to see how fast things change. I remember once in the early days of COVID where someone said, like, no, I'm thinking something like really long term, like 2 days from now. Like, things were so fast and just so much was unknown. And we had companies that really wanted to help and were willing to do pro bono. And they'd be like, okay, we can build this for you over the weekend. And then, but like, there was something of like, we can build a thing that can do optical character recognition and read this fax thing for you so that it could auto-populate something. And then by Monday, that wasn't the predominant thing they were using. It was onto a different form, or like most people weren't even using that form. And so it was just crazy.
Yeah, very interesting perspective from someone who was actually in the field. That's extremely interesting, and how the big question that you need, the big problem you need to overcome is first sort of streamlining all the processes, and that's but hopefully we will not get any new pandemic anytime soon. But I guess there were a lot of lessons to be learned.
Yes.
Okay, so are there any more questions from the audience? So you have a couple of minutes to type it up, and otherwise we can, I guess, then wrap up. Thank you so much. It was very interesting, very enjoyable. Thank you very much for
from the normal
sharing.
Sorry, I was just saying it's probably very different from most of the topics you have, but hopefully a good real world perspective.
No, yeah, it was very educational, because sometimes there are certain things that we don't think about, and especially there was how multiple support systems for the population, how they could be organized, and how people can get informed about them by actually looking at the integrative data. That is interesting and helpful. I think we have one more question. Oh, there is a thank you for a wonderful talk, and I wholeheartedly agree. Thank you very much.
Thank you. Nice to meet you all. Hopefully next time visit Boston.
That would be great. We would love to have you.
Thank you very much.
Bye.
Bye-bye.
Bye.